on PBMs. And what a PBM is not a peanut butter and mango sandwich. A PBM is something that is one of the hidden entities that profit from high drug prices in both here in West Virginia and across the country. They're pharmacy benefit managers. And tonight we're going to learn about them and about what we can do about them, what actions we can take to help rein in these pharmacy benefit managers in order to lower our drug prices. And so I'm going to go ahead and introduce our first speaker tonight, which is Dr. Dan Doyle, who has a very interesting video to share with us. Dr. Doyle.
Thank you, Gary. I'll try not to be the first speaker because really my job is to introduce the next speaker. And you'll all be happy to know that the next speaker is a comedian and his stage name is Dr. Glaucomflecken. But just briefly, I want to tell you a little bit about him. So this is Dr. Will Flannery of Portland, Oregon. Dr. Will Flannery is an ophthalmologist in Portland, Oregon. To survive during medical school as a married father of 2 children, he has told his story of being diagnosed with testicular cancer. And so here's this poor guy, he's got 2 kids, he's going to medical school, and now he's got testicular cancer. And he had done some stand-up comedy before that, but to survive it all, he started telling jokes and doing comedy again. And as he got into practice, he kept that up. And his stage name is Dr. Glaucomflecken. And so we have a treat for you to start this fairly serious program off with Dr. Glaucomflecken presenting a satirical and facetious, and some will probably say hyperbolic, approach to PBMs. So take it away, Eve.
Hey, boss, you got a second? Oh, hey, Jimothy. Yeah, what's up? Well, a lot of our customers are pretty upset about the cost of their prescription medications. Yeah, I bet. They're super high. Is there anything we can do to help bring that cost down? Oh, you're going to have to talk to the pharmacy benefit manager about that. What is that? The pharmacy benefit manager, the PBM. Jimothy, did you not study your health insurance chain of command? The PBM negotiates discounts with the pharmaceutical companies. Oh, and then they pass those savings down to patients? Oh, God, no. Ugh. No, they pocket the money, reap enormous profits, which actually increases the cost of medications to patients. Really? Yeah. PBMs run every aspect of the drug market. They set prices, and they determine which medications will be covered by your insurance, all to the highest bidder. Oh, God. Well, do you know where I can find one of these pharmacy benefit managers? What's happening right now? Hi, I'm the pharmacy benefit manager. I'm confused. Timothy, it's actually me, United Healthcare. Yeah, I know. You're also the pharmacy benefit manager? Yeah. Well, we go by Optum, but, it's all United Healthcare. Anything else you own? Oh, we have our own pharmacy, Optum RX. Yeah, all our customers have to use it. It's great. So let me get this straight. The PBM, that's me, decides which medications are covered by health insurance, also me, and which pharmacy, me again, the patient uses to get those medications. Vertical integration. We make $200 billion a year. It's awesome. Surely there's some kind of oversight, right? Somebody has to keep you accountable. You don't make $200 billion a year with oversight. How is any of this legal? Jimothy, when you make enough money, you get to write the laws.
Okay, I'm Thank you, Dr. Doyle. You have any other comments on this? That was pretty self-explanatory and very eye-opening.
It speaks for itself.
Yeah. Sometimes the best truth comes out in humor, and we do have a lot of details to go into about this scenario, this vertical integration, and how it affects our drug prices. And I'm going to introduce our next speaker now, who is Jane Horvath. And Jane has a deep background in Medicaid, commercial insurance markets and regulation, Medicare, prescription drug pricing, and reimbursement. Jane's a consultant on a variety of healthcare financing issues, including pharmaceutical costs. She advises state governments, foundations, private and public sector payers and providers, and consumer advocacy organizations like ours. She's testified on Capitol Hill and in many state capitals on drug cost issues. Jane developed the Center for Drug Pricing at the National Academy for State Health Policy and held research positions at Georgetown University, Johns Hopkins, and others. She has worked for the Medicaid directors, the U.S. Senate Finance Committee, and was a Deputy Assistant Secretary for Legislation on Health at the U.S. Department of Health and Human Services. So we're very pleased tonight to have Jane give us a little rundown here about pharmacy benefit managers and how they do what they do and how we can rein them in. Jane, take it away.
Thank you so much. And I really appreciate the opportunity to speak with you all tonight, because sort of my goal is to do as much as I can to make sure everybody understands this insane industry. It is so complex, and we're never as consumers going to get a grip on it until we all at least have a fundamental understanding of the craziness. And the one other thing, Gary, that you left out is that I worked for Merck for 10 years. And then when I left Merck, I did 3 more years of consulting with the biopharmaceutical industry, different companies. So I definitely know the industry, the pharmaceutical industry, and then from that sort of the relationship with the hospitals and the PBMs and all that stuff. So that's where I got a lot of my knowledge about all of this. So I'm going to share my screen. I hope. See. Share. Oh, and then to this. Sorry, I just got to move my little beginning. So we're going to roll right past that. So I'm going to start with the background. And basically, I do want to give you a background in sort of how things work briefly, and then also explain to you sort of how we got to where we are today, because it wasn't always this insane. And there's a bunch of factors about how we got to this level of insanity. Anti-consumer market behaviors. So there is the supply chain, and in a minute, I'm going to show you the financing chain, and people tend to get them all conflated, and they're really very different. So the supply chain, as you can see here, starts with the people who make the drugs, they produce the product. And then how the product gets around the country and to all these different places, the pharmacy and hospitals and stuff, it runs through wholesalers, regional distributors, specialty pharmacies, but it's the wholesaler and the specialty pharmacy that tend to have the direct connection to the manufacturer, which is important to know. So, and the most important thing about thinking about the supply chain, these are the people that own, they buy, they own, they sell the drug. PBMs never own a drug. They just, that's not their thing. So the supply chain doesn't involve health insurers. It does not involve PBMs. Okay, that is the most common misunderstanding or point of confusion that I find folks have. And then here's the financing chain where things get a little crazy. So this is where the confusion happens. It has nothing to do really with the wholesalers or other entities in the supply chain necessarily. And you could see here that I have put, because I think they belong there, the PBMs are sort of the source of all of this. Now, they got a lot of help from manufacturers in getting where we are today for sure, but they have situated themselves at sort of the center of this sort of healthcare financing chain. The PBMs have relationships with the manufacturers, as you can see, and they have relationships with the insurers. They have relationships with outpatient pharmacies because pharmacies bill, instead of billing the insurer, they bill the PBM. And the PBM reimburses the pharmacy, and then the PBM hits up the insurer to get paid back for what the PBM paid the pharmacy, for instance. Okay. So, and then the rebates that we all hear about, the PBM has negotiated with the manufacturer, and they're really based on volume, the amount of volume of a particular drug product that the PBM can drive for the manufacturer, the market share basically. And then also which involves where this drug sits on a formulary. Sometimes you go to the pharmacy and you have a $10 copay. Sometimes you have no copay if it's a generic. Sometimes you have a $50 copay. Sometimes you have a 25% co-insurance. And so the rebates and things like that are not things like that. The rebates reflect where the drug is on the formulary and the amount of discount that a manufacturer has given. And that's a very general statement, but it tends to be more true than not in most cases. Sometimes there's just an extraordinarily expensive drug and the co-insurance is also very high. So, excuse me, without regard to what the negotiation was between the manufacturer. You're never going to see $1 million drug with a $10 code. Excuse me, please. So I wanted to just run through briefly sort of who does what in the supply and financing chain, because everybody does have sort of a distinct role. So manufacturers, they bring the drugs to market, they set the price, and they actually can lease out their drug product to other manufacturers. And this actually happens with some regularity. So Merck might have a product that they lease to Sanofi to sell in France, for instance. And in France, Sanofi gets to sell, determine the price of it in France, but Merck manufactures, Merck ships it to wherever Sanofi needs it shipped to, and all of that. So that does kind of happen a lot, but that is within the ambit of what a manufacturer can do. And then the manufacturer plans for all the sales and marketing. So they bring the drugs to market, they set the wholesale price that you'll hear a lot of, but that sort of distinguishes a manufacturer from a repackager, from a pharmacy, from anybody else in the supply chain. They control the wholesale acquisition cost, which is generally considered to be the list price. So wholesalers, a lot of people think that wholesalers are part of the problem, and I could be wrong, but I don't think so. I think wholesalers, well, I know wholesalers buy in massive quantities, for a very good discount from a manufacturer. And then they distribute it to pharmacies and hospitals and whoever. So, they may be making less, a fraction of a penny of on a pill, for instance. So it's a very small markup, but because the quantity is so large, that's how they make their money. And then there's some other fees and things like that they can charge the manufacturer for different kind of services in managing or distributing the product as the manufacturer would like. So they buy in quantity, they store the drugs, in their warehouses, and they sell and they ship it to wherever it needs to go. Sometimes they'll ship very large quantities to, say, regional distributors who then take care of sort of the geography, the local geography of pharmacies, for instance. And also, this is where it gets a little confusing again. But a wholesaler can do several different things, and the wholesaler role has expanded, I would say, over the last 30 years. They can be a specialty pharmacy, which can mean many things, and I think we'll talk about that later, like what's a specialty drug? What are specialty drugs handled by specialty pharmacy? So they can also be a retail pharmacy. So for instance, a regional pharmacy, I don't know, like Kroger's, or in my area, it's the Giant supermarket. They all have their pharmacies. They're also licensed as wholesalers because, they ship to a central giant location, and then the drugs are shipped out, distributed to the giant supermarkets. And that is the name of the company, giant supermarkets. So they have to behave like wholesalers in terms of they have to meet the regulations for storing the drugs, and shipping the drugs, and accounting for the drugs, and accounting for handling of the drugs. So there's a lot of regional pharmacies that are also wholesalers, but they don't do this like, they're not global corporations. So PBMs, the focus of our evening tonight. So PBMs, they create the pharmacy networks on behalf of an insurer. In general, a PBM doesn't have different pharmacy networks for different insurers. They have their pharmacy network, and they present that network to the insurer for whom they contract. They operate the formulary, and that means that they decide which drugs are covered, which drugs are not covered, and which drugs are prior authorized, which drugs have quantity limits, and the tier and stuff that a drug would sit on. And the interesting thing I'll say here is that over the years, these big PBMs have started to play super hardball with manufacturers in terms of wresting rebates and other price concessions from manufacturers. They start just not covering drugs. And the last time I read it, which I guess was last year, sort of between the big three PBMs, that they just didn't even cover like 400 drugs. So when we talk about access and rationing and all of these things, when you talk about reining in drug prices, which is where all of these shenanigans started, you talk about people are not going to have access to drugs and things, and you need to just point to the fact that right now, like these major corporations that manage our access to prescription drugs don't even cover about 400 of them among the 3 or 4 of them, which I think is sort of a stunning thing to realize. And it just sort of indicates, I think, what a hot mess we are really in here. So they operate the formulary, they reimburse pharmacies and providers. So pharmacies get their drugs from the wholesaler, they give it to me, and then my pharmacy sends an invoice to the PBM, and the PBM pays my pharmacy, and then the PBM turns around and tells the insurer, said, hey, I just paid this claim for Jane Horvath at the giant pharmacy here, you owe me X. I mean, they do it like quarterly with millions of claims and stuff. On a local, in a very specific level, that's how it works. So then they also turn around to the manufacturers and say, like, we negotiated, a buck a script off of this drug, and in this last quarter, I paid for 2 million scripts. So you have $2 million. This drug going to rebate it. So health plans are all state, this is a bit of a tangent, but health plans are all state licensed, and not all states license PBM, although that is changing very rapidly. Really, until about 5 years ago, these guys were like the Wild West of the healthcare system. They weren't regulated, as we alluded to in the clip that we just saw. And but states have really come around and realized that these guys can be a very big problem if they are not regulated properly. And so they've started to do that. We'll hear later from Eve that once the states have done it, then Congress decides it's something they can do. And Eve's going to talk about that. So insurers, they contract with the PBMs. And if they don't contract with a PBM, which I can't think of an insurer that doesn't, they would do all of the things that the PBM now does, which is all of those things, which is why we have PBMs, basically. So basically, running a pharmacy benefit in your health plan has become insanely complex. And it used to be, when I worked for the Medicaid directors, they said the pharmacy benefit was the easiest thing, paying each claim cost a couple cents, everything was smooth, it was all under control. They didn't need to manage it, basically. It just worked fine. And then things started to get very complicated. And, it's because of rising prices. And trying to manage those rising prices through utilization controls like prior authorization and negotiating with manufacturers and squeezing pharmacists and all sorts of things. So it's become a lot more than insurers can handle. And so They started to take on PBMs just to manage claims as more people started to take more drugs, and then to sort of manage all this financial craziness. So, but anyway, I digress. So insurers set your premiums for your overall package of healthcare services. They run the grievance and appeals. They are all state licensed. They're not federally licensed, except for ERISA plans. So employer plans, most large employers are self-insured, and the government regulates them. The states do not. Pharmacies. So we have retail pharmacies. That's the brick and mortar stores that we all know and love. And the important thing to know, I think, about pharmacies is that they can't drive manufacturer market share. So they're not getting price concessions from manufacturers or anybody else for that matter, because they, except maybe generic drugs, they can drive some market share because they can maybe just stock the generic made by one company instead of the 3 other companies. In terms of branded products, they cannot, doctors, hospitals drive how many prescriptions and for what drugs, and pharmacies just fill them. So they don't make like profit off of volume of branded drugs or anything. They sort of stand apart from that completely. And then we have specialty pharmacies, which may or may not be open to the public, and they generally contract directly with manufacturers to handle specific drugs of a manufacturer. Those drugs are typically drugs that are high cost. They require special handling. They require special provider education in order to administer them. And there's one other thing that I just forgot. Oh, also helping patients with the drugs. The other thing, the tricky thing that a manufacturer has started to do, I would say in the last decade or so, is they hire specialty pharmacies to handle drugs that they don't want going into federal deeply discounted program channels, or they don't want potential competitor manufacturers being able to get the drug to be able to dissect it and figure out what's in it to go ahead and make a competitor product. So specialty pharmacies, run sort of this very defensive business operation thing. And then they also just do what a pharmacy should do with a very complex drug. So who doesn't benefit from high drug prices? The list is very short. It's insurers. Now, some people say insurers do benefit from high prices, but I really do disagree. And I say that high out-of-pocket costs are a symptom of the problem and not the problem. And I'm not saying insurers are walking with God. That's not my point here. My point is insurers get stung by the really high drug prices because they have to, through their PBMs, reimburse the pharmacy, right? And as I said, the pharmacy is not getting a big discount on these very expensive drugs at all. And so whatever rebates the PBM insurer might get, they still have to pay the full freight out to the pharmacy. Just so that everybody understands that piece of it. Patients clearly do not benefit from high drug prices, and government health programs do not benefit from, so like Medicare, Medicaid, state employee programs, prisons, none of those folks benefit from high drug prices. And the interesting thing, I've done this now several times over the years, but back of the envelope, and state governments in some way, shape, or form, your tax dollars support probably the pharmacy needs of maybe 25 to 30% of the population, depending on the size of your prison system and the size of your Medicaid system. So who does benefit from high drug prices? Research institutions, which is not what you would think. So, but the, large research universities and stuff, they get the NIH money, and they do the bench science, and they develop what's called the molecule basis of the drug, the active ingredient in a drug. And so they'll quickly run and patent that baby. And then when it does prove itself through the very early stages of development to be a promising, marketable, commercialized drug, a manufacturer will come in and either buy the patent or pay royalties on that drug to these research institutions. And obviously royalties are, as a percentage of sales, this, the price is higher, your royalties are higher. So they definitely benefit as the price goes up. Manufacturers benefit as the price goes up. Wholesalers benefit as the price goes up, depending on a portion of their contract that might be tied to the price. But in general, wholesalers are not really tied to the price. That's not their structure. Then PBMs benefit through the rebates and other things. And we're going to dive into that a little bit more. Got it. All this. So it wasn't always so. So the retail pharmacy benefit was straightforward and low overheads, 35 years ago. And that was because, number one, there weren't that many drugs, and not everybody in the country ate drugs or 4 or 5 or 6 prescriptions. But also, pharmaceutical companies priced their drugs to maximize sales, right? And they tried to be competitive with each other in a therapeutic class, and competitive in the way that we think about price game competition. You lower your price to get more sales, basically. So anyway, and so whether it was managed care or fee for service, PBMs paid the pharmacy claims without needing sort of strong cost management. And then we got more drugs to treat more illnesses. So more people are taking more drugs, which just on its face gets more complicated, sort of tracking all of that, identifying your pharmacies and needing more pharmacies in your network and things like that. And then the manufacturers in the 1990s started to focus on product price rather than price for the purpose of maximizing sales. And over the years, manufacturers use price increases to make Wall Street happy. If they've told Wall Street they're going to have a revenue of X, just raise the price. They don't sell really any more drugs. They raise the price. And I'm not kidding. I'm really not kidding. They have, their whole business model has been built on price maximization, not like it used to be sales maximization. I mean, you need some sales, but you don't need to grow your sales if you just increase your price, basically. And it's been a terrible, terrible thing for the country. And that's sort of when the PBMs stepped up their game, and everything has sort of escalated into a level of craziness that most of us even understand. And there is a guy who actually was a consultant to the industry and said, you're pricing too low. You need to price for the value of your product. Like, think of all the good that your product does. The light went off for manufacturers, like, oh, you got to do that. So, and that's what they started to do. But even the guy who started this whole ball rolling 20 years ago now with the manufacturers says it's completely out of control. Regrets his advice at the time. Why is this not moving forward? Oh, there we go. So again, evolution. So because of what the manufacturers did, and I do need to keep coming back to that because that is the source of the problem. So the increasing complexity and the cost of the drug benefit led to this much greater role for the PBM. And they do all of these things that we really don't like. It's this whole list of things. So, and then the growth of the PBM industry, the more they did, the more they get paid for doing, obviously. So they have grown into these very large corporations, and some of them make just on their own, in their own little silo of being a PBM, make more revenue in a year than Pfizer or Merck, for instance. And that speaks to what the problem is here. But as it grew bigger, then they decided like they needed to merge to also inflate the stock price and do all the, the market behaviors that we know and love. So the PBMs started to consolidate, buying each other up. So now we have, like, I should know the number, but I think we have 4 major PBMs in the country that cover like 90% of the lives, health plan enrollees. And so, that's a hell of a market consolidation, excuse my French. And then they decided the smarter thing to do would be to start consolidating, like running their own mail order, as we saw in this humorous clip at the start of the meeting. So they started creating their own mail order, and then in the last like 7 years, they've started to merge with insurers. So the level of self-dealing that goes on in that arrangement is eye-popping, if we could actually even see all of it. So but this is how the whole thing became so powerful and, in my view, so misaligned with customers and providers. These guys are global institutions at this point. The whole package, the PBM, the mail order, and the insurance, even like England, where we think they have national health insurance, US insurers are stepping into that market. It's a sort of fascinating trend there. So, and here's where we get to the business, their market behaviors that are a problem. So, and I've lumped them into a couple of things, but so they have inappropriate patient pay and access policies. And this is where the patient copay is more than the cost of the drug, or at least more than what the PBM is going to reimburse the pharmacy for, at least. This is outlawed federally now, but PBMs offer these because they are so powerful. They just, here's our contract, take it or leave it. And if you leave it, you get no customers anymore because the PBM is contracting with every other pharmacy in your neighborhood and not you. So you got to take it. And these contracts used to prohibit a pharmacist from counseling any patient on alternatives to a particular drug that might, work as well and be less costly, or if paying out of pocket, not using your insurance would cost you less. All the craziness the pharmacists tried to explain to patients, and the PBMs decided to prohibit that because it messed with their business. So again, that is outlawed now. Is a lot of states outlawed it, and the feds came in like 2 years. So, and then they also steer patients to their mail order. Again, this is sort of the self-dealing thing. So really are financial penalties because they charge patients higher copays for using a giant pharmacy instead of their Caremark mail order pharmacy. I mean, it's higher cost share, but it's a financial penalty basically for having consumer choice. And then again, in my view, people have different views of this, but I think independent pharmacies have been collateral damage in all of this PBM craziness. I don't think PBM set out to eliminate independent pharmacies because there's not enough of them for them to really even worry about it. But their strategy of competing, like Walgreens competing with CVS and like all of the large pharmacy chains competing with each other, it gets pretty dog eat dog. And the same contract that a PBM, Walgreens PBM will give to a Caremark retail pharmacy, which is trying to, hurt CVS Caremark because they're competitors. Give that same contract to an independent pharmacy, basically, just one contract. And it has devastating impacts for independent pharmacies, whereas CVS just makes a little less money than they used to with this contract. Now, I've seen in the papers where CVS and Walgreens fight over the contract provisions that they're giving each other, but independent pharmacies, they don't have that clout, and so they really suffer. And we're seeing a lot of closures of independent pharmacies, and they're the folks that are in the communities where Walgreens and CVS are not. They're in the rural areas. They stay there. There may not be enough market share for CVS to even go there. So those are the pharmacies that are in places where you really need them when people are underserved or really far from healthcare. And those are the folks that are getting driven out by all of this crazy business practice. And so more of them is sort of more business practice concerns, lack of transparency to the employer who is the client of the PBM. But they should be the boss, right? If I hire somebody, I'm the boss. But in this case, I hire a PBM and they're the boss, basically, unless you're like IBM. But if you're a mid-sized company, you don't know what the hell they're doing. Again, excuse my. They just don't. I was working in Maine with employer groups and all sorts of people on drug cost containment stuff. And the employer said, we have no idea what's going on. We have no idea really how the pharmacy benefit is managed. And I'm like, well, it's going to be hard to sort of structure change if we don't even know what the base is. But their contract doesn't allow them to know what's going on. That is the power of these PBMs. So, but they have found attorneys general of at least 10 states now have been examining PBMs for this spread pricing, which is where they pay my giant pharmacy $10 and they turn around and tell my insurer that they paid the pharmacy. So they're starting to stop that. And so they also have contract provisions that actually increase the spend, the amount of money that insurer spends on drugs, because the contracts are pretty tricky. And I got a peek at one time and I realized what the problem is this PBM guaranteed this state employee plan 19% of whatever the drug spend is back in rebates. And so that drives a whole bunch of mess, basically, in my view. So the PBM at the end of the day doesn't really even care what the spend is, as long as they get 19% of it back in rebates to the insurer. And I've heard insurers talk about, wow, we get so much money back, we get 20% back or whatever, without sort of realizing the spiral that's going on here because of this contract provision. One of the things I'm trying to do is really make sure people understand these things in the contract, because it means that the PBM doesn't want to cover lower cost drugs that come with lower rebates. For instance, Merck. Merck had a hepatitis C product. They were like the 5th to the market. They were, it's about all the eye popper Hep C treatments had come out the year before. And so Merck decided to basically put the list price of their Hep C product half of what the list price was for the other products. And in doing that, they weren't going to offer very much rebates, basically, or no rebates, because they said, we figure our list price is really your net price after Gilead gives you all these rebates. And the PBMs didn't want it because it increased their drug spend without any offsetting rebates. And so the Hep C product was basically a market failure for Merck. And I read this, people think that manufacturers are, crying the blues here for no particular reason, but it's a real issue that manufacturers have tried to come to the market with lower priced products and the PBMs refused because of that contract clause. We guarantee you 19 or 20% back on all your spend. So if you have a significant spend coming in, the Merck product was still like $40,000. If you have significant spend coming in and no rebate to say you've counteracted it, you don't take the product. So anyway, and I've talked about vertical integration here. So government responses. So I just sort of bucket what states had started to do. And again, they're way ahead of the feds, but this is sort of the eras, if you will, of PBM reform. So back 2012, 2013. So it started with laws. Independent pharmacies went to the legislatures and said the PBMs are killing us here. You need to do something. And so the early PBM laws really regulated PBM pharmacy audits and how PBMs paid pharmacies, particularly independent pharmacies, but the laws applied to all pharmacies in a state. Then sort of the next bucket of activity at the state level was to then go in and realize what the PBMs were doing to patients. So limiting the patient out-of-pocket costs relative to the cost of the drug, the gag clauses, and then AGs started to review some of the Medicaid and state employee plan contracts, which took years to sort of work their way through. We're only starting to see the results now, but it started way back then. So then in the next bucket, there was broader PBM business practice concerns. So states started doing transparency, requiring PBMs to report to the state on like the top spend drugs, the buckets of rebates and things like that. So in Nevada and Oregon were the first to really start down that road. And then we have 14 states enacting 25 laws. So you can see a state in 1 year is just going to enact multiple laws to deal with these very different and inappropriate market behaviors. 2019, there were 20 states and 24 laws, 2020, 20 new laws, and the feds enacted their own transparency law that mimics all the state PBM transparency. And the first reports based on that law are going to be coming out of the feds in next year, basically. 2021, 15 states, 21 new laws, and that focused on this program called 340B and PBMs trying to wash that program too. So all of this is all by way of saying that states have had to go back and back again and back again, because where they start to regulate, then the market behavior changes and they have to go back. So it's just an iterative thing. And I will say at the bottom here, this most important thing was the Supreme Court, the US Supreme Court at the end of 2020 handed a very big defeat to the PBM industry. They had been saying because they work for employer plans, which are federally regulated, that states can't regulate them. And the Supreme Court said, nope, that's not true. States have all the authority in healthcare rate setting to apply it to you. So that has really opened up a big window for states to continue to regulate the PBMs without them threatening to sue. And then also other rate setting around ERISA plans and stuff. It's a very important decision. And then Virginia, I looked up all the Virginia laws. You guys are definitely ahead of the curve. You basically have the Pharmacy Audit Integrity Act, the Cost Sharing Act that your legislators have built on. And again, West Virginia's had to go back and back again and back again and back again to deal with the evolving, changing, and the not good changing of PBM business practices. So, and legislators are either dealing with the effects on consumers or the effects on independent pharmacies. So yeah, the Virginia laws have been great. I would say West Virginia has been a leader in this space. And I'm not going to spend a lot of time on this. You'll have access to this, but basically the West Virginia laws were dealing with inappropriate patient cost and access policies, halting policies that disadvantage those super important independent pharmacies, and then improving market transparency. So, and this is in line and actually led many other states, but these are sort of the buckets of activity that all the different states are looking at when I gave you that list of all the different states and the number of laws that they've been doing. And then I can't see what the first one here. Oh, yeah. So in 2019, Congress got real bold and banned gag clauses in PBM contracts, which was hysterical because I think they were probably outlawed in 45 states already. So that's Congress right in there, right in the middle of the fight, right? And then in 2021 was that transparency law that I told you that the feds had, that Congress had enacted, and we're going to see the reports next year. But it mimics everything that states have done. Like states mostly do the 25 highest cost, most prescribed, or highest spend, highest increased drugs. So the feds are requiring reporting on the top 50. And then detailed data on the patient costs, rebates, fees, et cetera, all the stuff that states are already doing. But the important thing here, even though I am a little cynical here, but they're going to be able to get to ERISA plans, and states can't get the reporting necessarily out of ERISA plans in the level of detail that's that states can get. So that'll be helpful. Also, finally, the Federal Trade Commission finally stepped up to the plate. Pharmacies and other people have been begging the FTC for probably 3 or 4 years now to get on the stick with this and start investigating the self-dealing going on and the anti-competitive behavior of this whole PBM insurer mail order conglomeration. And finally this year, they decided to open an investigation. And now I'm going to turn to Eve, who is going to talk about the federal law, and I'm going to stop sharing my screen. Okay, I think I've done that. Take it away, Eve.
Thank you so much, Jane. I'm going to share my screen. Let me hit the right series of buttons. It's magic.
So while Eve's getting set up, I'm just going to explain that she's going to tell us a little bit more about what Congress is thinking about doing to rein in these pharmacy benefit managers and some action items for you all to consider. You ready to go, Eve?
Yes, I am.
Take it away.
All right. So, as bill names go, this is probably about a medium-sized bill name. Bill names are long, usually. This one is Pharmacy Benefit Managers Transparency Act of 2022. And as Jane said, they pulled a lot from what the states have been doing, and they're trying to make it into federal law. This was a bill that was co-sponsored by Senate Commerce, Science, and Transportation Committee Chair Maria Cantwell, Democrat, and Senate Judiciary Committee Ranking Member Chuck Grassley, Republican. It is a bipartisan supported bill. The goal of it is to shine a light on PBMs, the market, and to also empower the Federal Trade Commission and state attorneys generals to stop unfair and deceptive PBM business practices. So the bill will prohibit unfair or deceptive price practices. In detail, it's going to stop spread pricing and stop clawback payments. This is huge. It would make it illegal for PBMs to engage in spread pricing in which they charge health plans and payers more for a prescription drug than what they reimbursed to the pharmacy, which they're actively doing right now, and then pocketing the difference, the spread as profit. This practice can result in pharmacies being reimbursed less than their acquisition cost for a drug. And in the chat there, I think Kim Jones was saying that her local pharmacy directed her to one of the big pharmacies because they would have literally gone in the hole filling her daughter's insulin prescription because of stuff like this. The bill would also prohibit PBMs from arbitrarily, unfairly, or deceptively clawing back payments made to pharmacies, or arbitrarily, unfairly, or deceptively increasing fees or lowering reimbursements to offset reimbursement charges. It's ridiculous how much money they're scamming off of people. The next thing that this bill will do, it will incentivize fair and transparent practices in PBMs. There are some PBMs that are actually behaving responsibly. It's the big baddies that are taking advantage of everything. So the whole point is we want them to pass along 100% of the rebates to the health plans or to the payer instead of pocketing, and to provide full and complete transparency. It would also mandate an annual report to be made to the FTC, and it would enforce accountability. It would authorize the FTC and state attorneys general to enforce mandates, and it would protect whistleblowers, which is a big deal. Jude, if you could, I don't think Jude has access to the link. In the chat here in just a minute, I'm going to copy and paste this link. It has all the details about this bill. So what is our ask? Our ask is, well, contact your senators, contact your representatives, because once it passes Senate, it's going to go to the House for approval. So we want you to contact everybody, your senators and your representatives. Tell them to lower drug costs now by cracking down on PBMs. We want them to pass the Pharmacy Benefit Manager Transparency Act of 2022. You don't have to remember all that. We got a short link. You can hit that tiny URL and you can fill out a form and contact your senators and your representatives. Now, if you like what you saw here today and you're interested in doing a bit more, share your healthcare story with us, your challenges, especially if you've had problems affording medications, because so many of us have. I believe a Kaiser Family Foundation survey said that 29% of Americans have either had to delay filling prescriptions, ration, or just don't take them. They don't take their meds because they're so expensive. They're so expensive. You can check back to our website and look for more healthcare educational webinars, because you know what? Knowledge is power. The more we learn, the more we understand, the less they're able to take advantage of us. And so the more we can do to help get that information out there, we're hoping it'll help make a difference. And if you'd like to do that extra step to volunteer with us, send us an email. We'd love to hear from you. And I'm going to put those links in the chat here in just a moment. Gary, you want to take it?
I will. And thank you, Eve, for those action items. Excuse me. I just wanted to open it up for any questions from anyone. I know there's some questions that have been in the chat already, I think, for our speaker. And let me find a few of those.
Yeah, I apologize. I wasn't checking the chat as I was
No, that's my
blathering on.
let me ask a few of these questions from the chat, Jane. Kat says, I love my locally owned retail pharmacy. Is there any positives for retail pharmacies from having PBMs in the supply chain? We've heard that they've sometimes scam the pharmacies.
Yeah, that's what I was talking about, sort of all the ways that they undermine independent pharmacies. I don't think we should care Titan to Titan, CVS fighting Walgreens and stuff like that. I don't care. Let them sort that out. They got enough lawyers. It's when independent pharmacies get treated the same way as Walgreens treats CVS. That's the problem. And I would say even for all of these PBM bills around pharmacy treatment of pharmacies, they should really just be focused on independent pharmacies, in my view, because again, I don't know that CVS needs all these breaks myself. CVS is again, a global corporation. And if you wanted to just keep it narrow and make sure that everything is targeted to preserving independent pharmacies, you may want to do that.
And here's another question. Is there any legitimate positive role for PBMs from a consumer perspective? It seems like the consumers get the short end of the stick on this deal.
So, yeah, PBMs aren't meant to serve consumers, the bottom line here. But there are like nonprofit PBMs. There's some small PBMs that I know of that do, really good work on behalf of the payers in patient-centric ways. Trying to figure out how to improve adherence, like structuring cost sharing and stuff for drugs that, make sure people can afford their drugs, structuring their formularies to limit out-of-pocket costs, and, are just super helpful and are really at the service of their clients as opposed to the other way around.
Yeah, and here's one last question because we're running short on time, but here's a question from Alice. Says pharmacists also do not benefit from high prescription prices, if I understand right. Question.
Yeah, that's right. So in general, if they get a discount, it's a small discount. Although if it's a very expensive drug and it's a small discount, it's still money. They might make more money on generics, again, by contracting for, I don't know, my thyroid medication, which is made by like 5 companies, going through a wholesaler to get the best deal from a company, and then they'll, make a slightly larger margin on that thyroid drug than they would have made if they had bought it from another company, kind of thing. But yeah, it's a hard business being in a pharmacy. It's a low margin business. if you're independent.
And I see that Kat Stahl has her hand up, so let's let her ask her own question. If she'll unmute herself.
Yeah, thanks, Gary. You asked a couple of my questions that I threw in the chat, but a third of West Virginians at least are on the Medicaid program, and most of those in Medicaid managed care. And is there a difference in PBMs in Medicaid managed care versus what seems to me is pretty much a profit grabbing bad business otherwise? Is there a difference there?
Not really. Centene is a national company. Most people haven't heard of it. But anyway, they have the PBM contract for a whole bunch of states, either through the managed care, they go through the managed care plans, or the fee-for-service program. And the states of 10 states, attorneys general have started investigating these contracts and audited these PBMs and found out that they were ripping the Medicaid program off. Again, doing that thing of saying, paying my pharmacy $10 and telling Medicaid they paid my pharmacy $12. And Centene in 10 states now has owed hundreds of millions of dollars in each state. And I think, most AGs Centene is so prevalent in the Medicaid program, I think most AGs have opened up investigations into the Medicaid PBM. So no, they're not, they can't harm the patient in the way that private sector PBM could do. And I'm sure Centene does private sector work too. But in Medicaid, the patient copay is capped. So it's $8, right? So it doesn't matter how expensive the drug is or anything else. The PBM can't play with that.
Yeah, thanks, Jane, because I think that's of concern for our state legislators. If PBMs are not serving the Medicaid program in a way that saves our state money, and perhaps hurts us, that'll be something. And we're already regulating PBMs in our state. As I understand it, we're almost a leader state in this area, but there's probably more we could do, maybe in that Medicaid realm.
Yeah, I would contact the AG's office and see if they have initiated any investigation of it.
So there's another action item for everybody. And I see that we're at the end of our time, so I just want to have a few wrap-up comments. I wanted to thank all of our speakers and panelists and folks that showed up to hear about PBMs tonight, and just let people know that this was an activity that was put on by the West Virginia Healthcare for All Coalition, which is a coalition of West Virginia Citizen Action Group, West Virginians for Affordable Healthcare, West Virginia Center on Budget and Policy, and with special help from the West Virginia chapter of Physicians for a National Health Program, which Dr. Doyle is the state chair of that. So we hope that you found this interesting. And as I said earlier, this is being live streamed on Facebook, so you should be able to go to the West Virginia Healthcare for All Facebook page and share this with your friends to find out more and to urge them to take action on this. And with that, I'm going to thank everybody again for participating, and I'm going to ask our Eve, who's running our tech, to go ahead and turn off the recording and close this up. Thank you. Thanks, everybody.
Thank you.